Rapid HIV testing is easy to conduct by healthcare workers. However, this leads to the false assumption that we can overlook quality testing measures and still get correct results. We are now in an era where antiretroviral therapy initiation is solely based on rapid HIV testing results. An estimated 150 million rapid HIV tests are done globally per year, and reports of poor quality testing and HIV misdiagnosis continue to be noted in different programs, and these are largely due to preventable human errors. This short video is meant to highlight some of the avoidable yet common pitfalls that normally lead to incorrect HIV testing results. First and foremost, understanding and using the correct WHO testing strategy is crucial. For example, in high HIV prevalence settings, that is above 5%, any HIV positive status should not be given without two sequential reactive tests. Furthermore, do not use the A3 test kit as a tiebreaker test to rule in HIV infection following discrepant A1 and A2 tests. In situations where only the first test kit in the strategy is available, that is A1, an HIV negative status can still be given if the test result of that first test is non-reactive. But if the A1 test result is reactive and if the second and third assays are not available, the client should be referred to another clinic where all test kits are available. In low HIV prevalence settings, that is below 5%, a final HIV diagnosis must be given after 3 sequential reactive test results. If the prevalence in the target population of your program is unknown, it is recommended to use the WHO low prevalence strategy as the default strategy. If working within an MSF program, please follow the correct algorithm as per MSF HIV testing guideline. Remember that an algorithm is a specific brand of test kit combinations that must be followed for A1, A2, A3 serially. But if you're working within a National Department of Health program, please follow the Department of Health's algorithm. Nowadays, there are so many different rapid HIV test brands in the market, and different organizations usually recommend different test brands for their algorithms. These different HIV test kits also have different requirements for the amount of client blood drops to be added, together with buffer drops and time to results, and this all could have an impact on the HIV test result if one does not pay attention to this. It is crucial for the healthcare worker conducting the testing to always refer to the job aid that is normally stuck on the walls, or to an SOP, or to the package insert of the test kit. This is the first point of reference if a problem arises. Some reagents are already incorporated into the test strip. When we add the client blood sample and the buffer onto the test bed, as shown by the red arrow, the pre-infused reagents become fully reactive and they migrate with this client sample through the strip, as shown by the blue arrow. So ensure that the test kit is kept in the correct environmental conditions, as exposure to excess humidity and or temperature before the test will minimize their wettability and performance. The sample pad, as shown in the magnification, has a fine network mesh meant to facilitate lateral flow and filter redundant materials. As such, minimize pounding the glass capillary tube on the test kit sample pad as per video, as this might damage the sample pad's fine mesh. Rather, let the capillary tube just touch the sample pad and blood will flow from the natural suction pressure. As a consequence of a damaged pad after the pounding, testers end up adding more buffer than required so as to force blood movement. Don't force for a faster flow rate by adding excess buffer, as this can result in false negative results. Also, remember to check expiry dates of the glass capillary tubes, as they have an anticoagulant inside, and if expired, it could be difficult to expel the client blood into the test sample pad. Any visible test or control line, regardless of its intensity, validates the testing. For challenges with weak positives, always seek second opinion and or retest the client. Independent positive and negative control samples must be used at least once a week, and they can help to monitor the performance of the test kits and adherence to the procedure. Also, the testing facility must be enrolled into a proficiency testing program. Within any health facility, it is good to select a lead person for rapid HIV testing who shall supervise these activities and conduct refresher training to improve the quality of testing. And the training can cover role plays on how to deal with false results, including appropriate counseling messages. Remember to always emphasize to clients that rapid HIV testing is not offered to individuals taking ARVs, as this can cause incorrect diagnosis. More can be found in the MSF website.